Hello and a warm welcome to this webinar today on Pareto Education's Pharmacy First series. My name is Camille and I'll be presenting a short topic on the acute sore throat. So welcome to today's lecture. You'll find a series of these lectures on our YouTube channel, which were recently delivered live and now available via our YouTube channel. So today's lecture, as I mentioned, is on the acute sore throat. Quick introduction to myself. My name is Camille Khan. I'm a physician associate working in secondary care. I'm also part of the team at Pareto Education, delivering high quality education for the allied health professionals, including pharmacists, physician associates, advanced clinical practitioners and advanced nursing practitioners, nurses and paramedics. So wherever you fit in the multidisciplinary team, this webinar, but particularly this focus, will be for the pharmacists. If you're coming across Pareto Education for the first time, welcome. This is a clinical education company designing high quality resources for the contemporary clinician, whether you're working in primary care, community pharmacy, hospital pharmacy. We are developing high quality resources that will develop your fundamental knowledge and accelerate your career. You'll find us on a wide variety of platforms, including social media, webinars such as today, university outreach, and also live workshops as well. So do keep an eye out for us. If you are interested in joining our social media handles and joining our pages, please look at the following links. You can see our handles for Facebook, Instagram, TikTok, YouTube, and we also got a pharmacy WhatsApp group as well that you're welcome to join. If you are able to scan your phone on the QR code, you'll be able to join the WhatsApp group as well. So quick introduction into today's lecture. We'll cover the signs of a severe sore throat, possible differential diagnoses, including the severe diagnoses as well that can manifest as sore throats. We'll look over the scoring criteria, how to select your antibiotics of choice in pharmacy first settings, how to follow up, and also safety netting as well. So that's the contents for this lecture today. For pharmacy first, there has been inclusion and exclusion criteria. So the main inclusion criteria for pharmacy first is for adults and children aged 5 and over, and they must be presenting with signs and symptoms of an acute sore throat. These are possible candidates that you would see in your pharmacy first settings. And any pregnant individuals under the age of 16, they would be excluded as well. So any patient that does not fit these inclusion and exclusion criteria should be sent to their general practice. Remember, in this case, there are a few different causes of acute sore throat, which we'll mention in this course of this lecture, but we are trying to here treat group A streptococcus infections. That's the focus of pharmacy first, one of the most common causes of acute sore throats, and that's what we're trying to help our patients with. Just remember, there are some vulnerable patient groups that you should be aware of that may manifest with acute sore throats, and they need to be more carefully monitored and given strict safety netting advice. So when you're talking about immunosuppressed patients, firstly we'd start with cancer patients on chemotherapy, any patients on methotrexate, HIV AIDS patients, especially if they have a CD4 count of less than 200, severely suppressed, any patient that's had a transplant, and any patient that is on biologic medication including infliximab, etc. Remember, sore throat can be a manifestation of cancer as well. So acute sore throat, you should always rule out the red flags of cancer. Throat cancer, head and neck cancer can manifest as issues with the throat, whether that be sore or otherwise. So other questions you should ask your patient, especially if they're a smoker or they're a 40-50 plus age bracket. Any weight loss, any lack of appetite the patient has, going beyond just the acute phase of the severe sore throat. A hoarse voice, a patient having night sweats is also a red flag. A patient having difficulty swallowing would also manifest as a red flag in this instance. So here's a short case that we can consider. So a 4-year-old boy presents to the GP with his mother. She reports he has developed a fever and a sore throat 3 days and is now presenting with a rash. On examination, he's febrile, flushed, lethargic, widespread erythematous rash over his trunks and legs, and he has a rough texture of this rash. When you examine the throat, he is having a swollen red tongue with cervical lymphadenopathy. What do we think is going on here? Feel free to pause the video to consider. This patient is showing signs of a scarlet fever, which is characteristic of this sandpaper-like rash, swollen tongue, and lymphadenopathy. Patient should be given 10 days of PenV for an underlying Group A Streptococcus infection, and advised to start to not go to school, and also public health should be notified. So remember, this is one of the manifestations of a sore throat, acute sore throat, so you should be aware of it when you're managing pharmacy first patients. So this child, scarlet fever is a highly infectious disease, so he should be given these antibiotics for 10 days PenV, and this is a picture of the characteristic tongue that you're likely to see, and the manifestation on the face, the skin as well. So just looking at this picture, this is another differential diagnosis that you may see in a patient that's presenting with a acute sore throat. Does anyone know what potentially this could be? We're looking at a potential quinsy here. You can see the large swollen tonsil, deviated uvula. So this is actually a peritonsillar abscess, which is a complication of acute tonsillitis, where pus or discharge is accumulating in this peritonsillar space. One of the key signs and symptoms of this is trismus, where a patient will be unable to open their mouth fully without significant amounts of pain. Of course, throat pain as well, and fever. Main risk factors for these kind of patients would be recurrent tonsillitis. Younger patients are more likely to develop quinsy, and patients that are male, and also smoking as well. The main thing to do for these patients is have a look inside the mouth. These are not patients that could be dealt with over the phone. So examine with a tongue depressor, and if there's unilateral swelling in the back of the throat and the uvula is deviated, and this would require admission to hospital, referred to the ENT specialist, ear, nose and throat. So if you look here, you've got the Liverpool peritonsillar abscess score, and gives a grading of different points for different risk factors, and that would give you an overall score of if a quinsy is likely or less likely. So remember, unilateral sore throat, trismus, male gender, and hot potato voice, which I won't try and replicate here, but I'm sure you can view over YouTube. Management, NSAIDs and antibiotics. In more severe cases, patient may need needle aspiration as well. Another common differential diagnosis is glandular fever. So this is commonly affecting younger patients, caused by the Epstein-Barr virus and transmitted by saliva. So patients will have a fever, sore throat, malaise, and prolonged fatigue as well. When you see the patient, there will be edema around the uvula, around the eyes. There may be a particular rash of the palate. There will be a generalized lymphadenopathy, and this rash, as I mentioned as well. In some patients, you may see some signs of jaundice, and in some examinations of the abdomen, you may find the spleen enlarged as well. This is the typical rash that you'll see in glandular fever, and as I was mentioning, the palate, the particular rash of the palate. And this is glandular fever. Epiglottitis is another differential diagnosis that you should be aware of when dealing with sore throats, and this is the inflammation and swelling of the epiglottis. mainly caused by infection. So what you will have in this case is a rapidly developing sore throat, breathing difficulties, drooling, and difficulty swallowing. So this is the first time we're seeing breathing difficulties. In these patients, it is a medical emergency. You won't see it very often, but if you do see it, this patient needs to be admitted to hospital and transferred immediately. So this is the anatomy of what you may see. But like I was mentioning, don't try to examine the throat in this patient. Don't try to force the mouth open. If they're having any breathing difficulties, if they're having an acute, rapidly developing sore throat, get them into hospital. This is what they see on small endoscopy when the ENT specialists do examine this patient finally. So again, here are some red flags that you should consider for a patient presenting with sore throat. Whether a patient has epiglottitis, if patient is having severe complications, severe illness, severe fever, deviated uvula, unable to swallow, drooling, trismus. All these patients need to be sent into hospital for same-day review. And like I said, these are the red flags. This is, of course, the news chart that you should be familiar with, and use this to take observations for your patients. It will help in your documentation and also safety netting, and it's a clinical part, or a crucial part of clinical documentation, which will help you stay safe. And if a patient is scoring high in the news, then potentially they would have to go into hospital. So this is the main FeverPAIN scoring system that we use for Streptococcus pharyngitis, which is the main diagnosis that we're trying to make here. And as you can see, each of these elements will give you a scoring. So if a patient has a fever within the last 24 hours, absence of cough, that would also give a point. Symptom onset of less than 3 days. Purulent or pus on the tonsils and severe tonsil inflammation. All of these elements will give you points towards a possible Streptococcus pharyngitis diagnosis. You can see here how the main difference is. You've got the swollen tonsil, the purulent tonsil as well, and the throat redness. And this is how it may manifest clinically on examination. So here is what to do. If the FeverPAIN score is 0 or 1 and you clinically feel that the patient's possibly not got a bacterial infection, you would advise patients to do self-care. You can advise them Difflam spray and advise them antibiotics are generally not needed for these. Patients should take symptomatic over-the-counter relief, things like honey, drink adequate fluids, and as I mentioned, it's unlikely that this is a bacterial infection, so antibiotics are not recommended in these patients. Ask the patient to return if there's no improvement or the patient worsens. Again, a reminder of the FeverPAIN score. If patient is having a FeverPAIN score of 2 or 3, again you can consider self-care and pain relief. There is like almost a 50%, so you could consider a delayed antibiotics choice. But for these patients, giving antibiotics is unlikely to give massive clinical improvement. So you could consider a delayed script or to return sooner if the symptoms don't improve. Remember, this is a clinical decision. So if you were to decide to give the patient antibiotics based on the patient discussion and the agreement, that would be fine as well. Again, another reminder of the FeverPAIN score. If this time the patient has 4 or 5 FeverPAIN score, if they've got some mild symptoms, then you could consider a self-care. But generally, for these patients, especially if they're exhibiting severe symptoms, you would consider an immediate antibiotic. And then ask the patient to return if there's within 3 to 5 days if there's no improvement. So remember, the chance of isolating Streptococcus bacteria is high for these patients. So what antibiotic should we give? we should give Pen V based on patient allergies for 5 days, and here is the BNF guidelines on what we should give based on the age of the patient. If the patient has a suspected or a reported penicillin allergy, we can consider clarithromycin, although it's not as effective. Again, here are the guidelines from BNF on the doses. And finally, if the patient is penallergic and penicillin, pregnant as well, erythromycin is given for these patients for sore throats. And you can see again the doses from the BNF. What to do for follow-up wise? If the patient is not improving or patient is worsening, then you should consider informing the patient to go back to their general practice to get more in-depth examination seen by the general practitioner. If the patient is rapidly progressing or you feel it's epiglottitis, then for those patients, they need to go to hospital. So this is just some self-care advice that you can give to your patients. You can find this online, and this just gives your patient advice in what to do if their symptoms deteriorate or change. And it's quite a good leaflet that you can hand over to your patients for safety netting. So that's the end of the lecture. If you have any comments or questions, please leave them below. Please check out our website, paretoeducation.co.uk/CPD for other available CPD courses that we run that are externally accredited. And as a reminder, here are our social media highlights, and you can follow us there for other awesome content. Thank you for joining me today, and have a pleasant rest of the day. Thank you and goodbye.